Spoštovane kolegice in kolegi, ladies and gentlemen, dear colleagues, it is my great pleasure and honor to welcome you again to our traditional, we can say it's a traditional, yes, it's the third time, the evening debate on SGLT-2 inhibitors. We have our distinguished guest speaker from our neighboring Italy, Professor Paola Fioretto. For our younger colleagues, just to briefly present Professor Fioretto, she is a professor of medicine from University of Padova. She was a past vice president of EISD. She is a member of all these prestigious associations from diabetic kidney disease. She published numerous publications on these topics, and she also has been awarded for Golgi Prize by EISD. And today it's just a perfect timing for this debate because just today our National Health Institute of Slovenia just published the new reimbursement policy regarding SGLT-2 inhibitors, and there are no limitation to use SGLT-2 according to SMPC, which is really a good information. And of course, this can be also prescribed in our GP level. So I think it's a good win. It's a good treatment possibilities for our type 2 diabetic patients. And of course, because we have really evidence-proof concept of this therapy. So Professor Fioretto, thank you for coming, for taking your time to be back in Ljubljana. What's new in Italy? What's new in your clinic?
First of all, thank you very much. Thank you to the colleagues from AstraZeneca for inviting me, and to you. Is a pleasure for me to be here. It's also very easy. I worked all the morning in the wards, and you know, it's so close. And I'm very jealous because in Italy we don't have this reimbursement policy. I hope that our poor country will will do the same as you did. We are getting better. The reimbursement policy has changed recently, but still the GPs cannot prescribe, for example, and still we have some limitation in the use, but it's getting better all the time. So I hope that soon we will do the same that your country did, because the evidence is there, and I think that our patients have the right to get the best care they can. So I think that that's moving, but not yet.
Okay, let's start our debate on SGLT-2 with the update of EISD ADA consensus. At the end of the year, they briefly updated the consensus, and of course, we can see now more profiled patient profile regarding each therapy, SGLT-2 and GLP-1. They put the new data, new evidence also with all these primary prevention studies, also the new kidney data. How do you see this consensus? How is changing the paradigm of the treatment of diabetes?
I think that already the previous consensus was a big change. And because the evidence is adding up so quickly, we needed a sort of an update. And I think that, to me, the most important change is the fact that you should use SGLT-2 inhibitors and GLP-1 receptor agonists on top of metformin, regardless of the hemoglobin A1C of the patient, because the question was all the time, what if the patient with metformin is at target? What should we do? So this is a very important change, but I think that the cardiologists have been more brave than we, in that they don't necessarily expect you to use metformin first. And I kind of agree with that. I think that despite the fact that in the majority of the trials, patients were already on metformin, but they were also already on other drugs, when a patient is diagnosed with type 2 diabetes, why not to start with the SGLT-2 inhibitors? I think that from the analysis from the trials, patients who were not on metformin got the same benefit. So it's not that you need metformin to get the benefit. So I think that it's time to change, and the evidence for cardio and nephroprotection, even in primary prevention, not only in progression, is now strong enough to start thinking that maybe we should start with these drugs first. Or at least to start from the beginning with an association. But patients should have the right to receive the best drug.
So, Professor Fioretto, you're really an expert on kidney disease, diabetic kidney disease, and you wrote just recently the commentary in Lancet Endocrinology about this topic. How the new data, let's say credence data, change the way we will prescribe now this therapy in this patient population? How solid are the data currently in kidney prevention? Let's touch this topic first.
Of course, we needed a kidney study, which is credence. But in credence, the population, of course, is patients with chronic kidney disease. But we already had the evidence from all the studies that there is a very strong nephroprotective effect. That the first evidence was from EMPA-REG, then we had the Canvas, and then we had DECLARE. And so, of course, for the label, you always need a dedicated study, and we will have now the DAPA-CKD and the EMPA-Kidney. So we had to have that, but was not a surprise. Was expected. In fact, it was stopped earlier because of the excess of benefit. So it was supposed to last longer. So I think that credence was only confirming what we already knew. And I think that there is no question that for patients with advanced kidney disease, we should use these drugs. The problem is that credence enrolled patients with the GFR down to 30. But at least for the time being, we are supposed not to start an SGLT-2 inhibitor if GFR is below 60, and stop if it goes below 45.
Why it's not changing? I mean, if we have now the
I
data,
don't know why it's not changed that,
protection
because that indication is based on the efficacy on lowering hemoglobin A1C. And so we know that if the patient has a low GFR, the effect on glycemia is not very strong. But we know now that you can prevent heart failure, prevent kidney disease. So I don't know why it takes so long for the label to change, because the guidelines have already changed, because the ADA, after credence, already in June, they recommended to use it down to 30. So I don't know why this is not happening. But when it comes to kidney disease, credence is clearly demonstrating that if you have proteinuria and advanced kidney disease, you really decrease the risk to go into end-stage renal disease. But now we have solid evidence, especially from DECLARE, that SGLT-2 inhibitors are effective in primary prevention of diabetic kidney disease, because in DECLARE, the majority of patients had normal GFR. By exclusion criteria, patients should not have had a GFR less than 60, and still there were 7%. So the majority had basically normal GFR, the mean was 85, and still there was a very strong effect on the solid renal outcomes. In addition, the investigators of DECLARE have presented at the EASD last year the data on albuminuria, which to me are very, very important. They are not published yet, showing that as we already knew, when you give a SGLT-2 inhibitor in a patient with micro or macroalbuminuria, you have a very fast decrease in albuminuria, is around 40%. But the important finding of DECLARE is that in patients who were normal albuminuric at the beginning of the study, who were the majority, there was a marked reduction in the risk to develop microalbuminuria. To me, that is primary prevention. Now, these days, everybody is talking only about eGFR, but as diabetologists, we know that microalbuminuria is very important, not only for renal outcomes, but also cardiovascular. And as diabetologists, to me, to be able to prevent the development of microalbuminuria is a very important finding.
And all these patients were already using ARBs and ACE inhibitors, and if you use CGLT on top of that, you get this synergistic effect or not regarding the reduction of albuminuria?
Sure.
Or if you compare each drug separately?
In the trials, the majority of patients were already on ACE inhibitors, ARBs. Of course, in DECLARE TIMI, depending on the GFR level, the proportion of patients with normal renal function on ACE inhibitors ARB was a bit less, but if you do subgroup analysis, it doesn't matter whether you are on diuretics or ACE inhibitors. So I think that on top of that, because which proportion of your patients with type 2 diabetes are on ACE inhibitors or ARB? Very high, because they are all hypertensive, right? So.
And also in credence, I mean, 99% were using.
Credence,
they were really well treated regarding
renal patients. Yes, credence, they were all, basically all.
Can you comment, because credence was the first trial which has a primary outcome, a kidney disease, let's say. Is it this composite meaningful for you? Because it was a composite of cardiovascular death and doubling of serum creatinine. How do you look on these endpoints? What is missing? Or is this data enough to get this statistical significance? Because you put everything together and said as a primary kidney endpoint.
In credence, they put in also cardiovascular death.
Yes.
And if you take that out, is even stronger. So I prefer the only renal endpoints. But in credence, it was a very solid endpoint because all patients had proteinuria from the beginning. So proteinuria is not part of the endpoint. It's only doubling of serum creatinine, or in that case, reduction of 40% of GFR, and stage renal disease, renal death. Renal death is very uncommon. It means that you die while you are waiting for dialysis, or if you refuse dialysis. So it's very small number.
It was always a mystery. What is renal death? What is
renal death is something, is that. Because usually patients die from, anyway, they don't die from the kidney, they die from the heart, right? But the renal death usually is meant the few cases of patients who are waiting until they start dialysis, or they refuse dialysis, or something like that. It's a very small numbers in the trial. So I prefer the composite endpoints where there are only the very solid renal endpoints. If you put together also albuminuria, like very commonly is used, then in some circumstances, like for GLP-1 receptor agonist, you use the same composite, macroalbuminuria, GFR loss 50%, and stage renal disease, it may be significant, and then you realize that it's all driven by albuminuria. So I prefer the more clean composite, renal composite.
You just mentioned GLP-1 analogs. If we compare the data, which are less solid regarding the kidney protection than SGLT-2, can you comment, or do you think the addition of both would even more decrease the albuminuria? What is your opinion? Because eventually patients will need first injectable, and first injectable will be GLP-1. So metformin plus SGLT-2, and then GLP-1, which you can use all the way till OGFR 15, or?
Well,
What do you think about the data on
the
GLP-1
data
and
is
the
that
kidney?
they were not very lucky, because I think that if LEADER and SUSTAIN where the data of these trials were released before EMPA-REG, wow, I mean, you decrease albuminuria. Albuminuria is important, right?
It's a marker of the disease.
Sure, but it's important because if you can decrease albuminuria, you suppose that you slow progression, okay? Having said so, after EMPA-REG, where you have a decrease of end-stage renal disease, doubling of serum creatinine, only proteinuria is not that impressive. And if you take all the clinical trials, there has been a very nice meta-analysis comparing GLP-1 and SGLT-2. If you take the composite with proteinuria, is significant. There is a decrease. But if you then look at the individual and remove proteinuria, there is no effect. While, of course, it is unchanged with SGLT-2 inhibitors. Having said so, I think that when it comes to patients with chronic kidney disease, we are all aware of the fact that if your GFR is low, you can protect the kidney with SGLT-2 inhibitors, but you don't improve glycemia. And we should never forget the importance of glycemic control for different reasons. So in that specific patient where, let's say, you don't have a good glycemic control, you will end up using an SGLT-2 inhibitor as you use now on top, of course, of ACE inhibitor to protect the kidney, but then you need to improve glucose. And then you can use a GLP-1 receptor agonist. Some of them can be used down to a GFR of 15. So to me, that's the ideal combination because anyway, some influences on the kidney of GLP-1 receptor agonist is out of doubt. For now, we have only data on proteinuria. I'm aware of only one ongoing trial with semaglutide in kidney patients. Dulaglutide, they are not interested. They did a short-term small study, the word 7, but is for efficacy and safety, is not really a dedicated study. So I think that is an excellent combination. To me, is the ideal combination. I don't know in the future kidney studies with SGLT-2 inhibitors, the lower limit of GFR that we will use, probably even below 30. And with this, for glycemia, you go down to 15. So to me, that's ideal. With all the cardiovascular benefits of both classes, of course.
If the drug SGLT-2 really significantly decrease this albuminuria, should we use it also in type 1 in that regard to prevent the kidney damage in type 1 population when ACE inhibitors are paramount? Do we have any data on in this area?
Well,
how promising is to prevent kidney disease in this patient population?
Okay.
Because the mechanism is a little bit different.
Well, the first study demonstrating an important renal hemodynamic effect in diabetes was done in type 1, but the return in circulation in patients with hyperfiltration or normal GFR, with normal albuminuria, without hypertension, so no drugs, only insulin, clearly demonstrating a very important hemodynamic effect. I'm not aware of any study on the kidney in type 1, but of course there have been trials with DAPA and sotagliflozin looking at the EMPA, also looking at the efficacy and safety of these drugs in patients with type 1. The duration was maximum 1 year. And I've seen some data, but they have been presented but not published with sotagliflozin, where also in type 1 diabetes there was an hemodynamic effect, a reduction in GFR, although it was not, the magnitude was less than in type 2, And the majority of patients were normal albuminuric. So there was some influence in those who had microalbuminuria reduction. So it looks like also in type 1 there is maybe a bit less. I'm thinking ongoing trials. I think that in the EMPA kidney, they enroll also type 1s. But other than that, I'm not aware of studies. Of course, it would be important to test that aspect also in type 1. We know that the proportion of patients in type 1 developing diabetic nephropathy is going down because of the improved glycemic control, but still.
There were recently some reviews regarding the why SGLT-2 inhibitors really progress the kidney function. And it was one of a hypothesis also on slowing or reducing the kidney congestion, like that you reduce this interstitial space in kidney and you reduce inflammation and also necrosis. How solid is this theory?
That's, I mean, is possible. There is not very solid evidence in humans, but I think that the anti-inflammatory, anti-fibrotic effect, of course, predominantly shown in animal models is a very important one. We have now some data also in humans with DAPA. A few years ago, there was an interesting paper, and also with canagliflozin, that in patients receiving these drugs, there is a decrease in the urinary excretion of markers of inflammation and fibrosis. So there is some indication that also in patients with type 2 diabetes, there is this kind of an effect. I think is very important, in addition to the hemodynamic, of course, that we all know. And the other effect that I think is interesting is a lot of people are working on that, the improvement of hypoxia for different mechanisms. The first one is, of course, that a lot of energy in the kidney is due to the reabsorption of glucose and sodium in the proximal tubule. And by reducing that, because you inhibit the reabsorption, you save a lot of energy. The other one is the observation that during SGLT-2 inhibition, there is an increase in hematocrit that is not only due to the hemoconcentration, but also to an increase in red cell mass because of a stimulatory effect on erythropoietin. So, of course, if you have more red cells, you deliver more oxygen to tissues. And finally, an interesting aspect is in animal models, the observation that in models that mimic acute kidney injury, there is a protective effect of the administration of SGLT-2 inhibitors. The model is a peculiar model. These models are models without diabetes. But in humans, we were worried initially that SGLT-2 inhibitors would increase the risk of acute kidney injury. And now, from the EMPA-REG in the appendix of the appendix, but DECLARE has clearly demonstrated that there is a significant reduction in the risk of acute kidney injury. One of the factors accelerating progression of kidney disease is the episodes of acute kidney injury. And if you work in the wards in internal medicine, I don't know if you all work in diabetes outpatient. If you work in internal medicine, acute kidney injury is, all patients. All you need is to have a tiny increase in creatinine. And I don't know why, but in type 2 diabetes, there is a lot of evidence that is much more common than in patients with similar features without diabetes. So another important aspect is to reduce the occurrence of acute kidney injury.
So currently, with all the evidence we have, would you still leave the therapy if the OGFR go below 45, or would you discontinue the therapy? now with your patients? Let's say if you have someone and it's coming on your clinic and the OGFR is around 35, and you know that the benefits will go all the way till 30, would you stop using the therapy in this certain patient population?
I personally don't,
Okay.
but I cannot, I think that the label is something that really needs to change.
Okay.
I don't know what you can do, but it needs to change because the evidence and the guidelines are there. But I don't have any problem even starting an SGLT-2 inhibitor if the GFR is below 60. But that's my personal, of course. Yeah.
Okay.
And, in the wards, I work in internal medicine, my colleagues who are not necessarily doing diabetes, they frequently start, when patients have heart failure, for example, they start SGLT-2 inhibitors. I said, okay, fine, just keep in mind that you need to give them something else to lower glucose.
Okay. Yeah.
I don't think there is any problem related to safety. So I don't think I take the patient to any risk. Okay. So I feel comfortable doing it.
That's my next question, safety. Is it any new update regarding the side effects? Let's say in the last year, you are reviewing a lot of articles from this matter. Is it any, what should we be concerned? There are foot ulcers and amputation, which is a little bit of a red sign there.
Yeah,
but still, the data in Credence were reassuring a bit.
Yeah.
Can you comment this a little bit?
Yeah, I think that, again, the most reassuring data come from the large cardiovascular and now renal outcome trials. And in this regard, DECLARE was very reassuring because, of course, after all the signals, they were very careful. And there was really no signal for increase in DKA. The same was true in EMPA-REG. There was no signal for increase in amputation or fractures, so it was very reassuring. And there was a decrease in the risk for acute kidney injury. Now, all the problems with fractures and amputations were with canagliflozin from the canvas, right? So.
And a higher dose.
Sorry?
It was higher dose.
See, the 300.
300.
Yeah.
Because
now,
Credence was 100.
About Credence, because it was stopped before time, was obvious that had to be positive for the kidney, right? So my worry was, what about the side effects? So the first thing I looked in the paper was side effects. And I was very surprised, but also relieved that there was no signal whatsoever for amputations and for fractures and DKA as well. And there was a decrease, although didn't reach significance, for acute kidney injury. And those are very difficult patients. Those were patients with very advanced kidney disease. So I think that we need to keep in mind that the dose of Cana was 100, yes. Not 300 in that trial. I don't know whether that makes a difference, that I don't know. But I think that also for Fournier, in the DECLARE, there were the data and there was no signal. So I think that the ADA and EASD, in the newest version of the recommendation, they recommend careful evaluation of the foot ulcers and the situation, because of course they recognize that there may be, there have been some signals that we should not ignore, but that doesn't mean that the patient with this kind of problem should not be treated. They recommend to careful evaluation.
But still there was a comment in Credence that the patients were really carefully selected regarding the peripheral arterial disease, this problem. So in a real life, it's very difficult to decide.
I think that is not
they're very
easy,
sick patients,
It's not an easy decision, and I think that the ADA-ESD, I appreciated that point, because I think that we need to be careful, because if you are careful, like in Credence, then you don't have a problem. But when they were not careful, it was a higher dose, they did have a problem. So,
regarding any other side effects, infections, I mean, this
Well,
debate is over.
Of course,
let's
we
say,
know
yeah.
that urinary,
Genital,
genital
yes,
is
but
always,
yeah.
but usually in the clinical practice is not really a big problem.
Let's touch a bit on class effect. It's very modern because you have different compounds in the same class now. In Slovenia, we have DAPA and EMPA. And we have different designs of these outcome trials, different study populations. How much is side effect? How much is the class effect on each compound? We can say that they all work the same. They all block these receptors. And should the effects be the same?
The mode of action is the same. We know that canagliflozin is less selective for SGLT-2 because it does work also on SGLT-1, although there have not been reported any problems with malabsorption, diarrhea, or anything, any intestinal level. But we know that. And so far, at least to me, I consider the results being in the direction of a class effect. Now, if you take, I don't know, heart failure, every single study, doesn't matter patient population, primary prevention, secondary prevention, patients with normal renal function, patients without cardiovascular disease, or versus with prevention of heart failure. If you take kidney, I think that is the same. There are some small differences in terms of primary prevention, development of makroalbuminurije. We have that evidence in DECLARE and in CANVAS. In EMPA was not. But I think that the effect, I think is a class effect. Even in EMPA, when they analyzed the changes in the normal albuminurics, in albuminuria over time, the curves were different, but still they didn't have a significant reduction in the number of patients who reached the level of micro. So I think that is similar. The differences that we had so far is on MACE, right? But the patient populations are very different. So I think that, in fact, if you take DECLARE and you consider the patients who had a previous MI, there has been a paper on circulation last year, those patients have a significant reduction in the risk of MACE and cardiovascular death. So I think that it depends a lot on the patient population, but my personal feeling is that is a class effect for everything, heart and kidney.
Were you surprised when the DAPA heart failure data came out? Also the benefits in the population without diabetes regarding the heart failure?
No.
How did you receive this information?
It was very exciting, and I think that I was somehow expecting that because there is all the indications from the mode of action of these drugs suggest that these renal and cardiovascular effects don't have anything to do with glycemia. So I was not really surprised. I was not expecting such a strong effect, honestly. Because, in all trials, there were not a lot of data on ejection fraction. There were some analyses, but not much. Here, patients were well characterized. They were really sick, and the effect was very strong. The fact that there was no difference between patients with diabetes and without, somehow I was not surprised. I was very impressed by the fact that patients already on Entresto did have a benefit, because that is something clinically very, very relevant.
If we summarize this part, who is the ideal candidate, let's say type 2 diabetic patients, which is the best profile who would fit into the category that we should add on SGLT-2 inhibitor, or we should go to GLP-1 maybe just to comment, because this is now a huge dilemma. If you have metformin, and then after, if you have established CVD, you can decide upon SGLT-2 or GLP-1.
Yeah.
Can you comment?
Yeah.
What's your feeling regarding this classification or decision-making on the therapy?
You know, there are different, there is a huge area of patients with different characteristics. You started from the probably most difficult one, those with established cardiovascular disease, where we have evidence with the GLP-1 receptor agonist that there is a reduction in 3-point MACE, but there is also evidence with SGLT-2 inhibitors, although in those studies there was no significant reduction, let's say, in MI. But if you take patients who already had an MI, you have a very important declare a very important reduction in 3-point MACE and in cardiovascular death. So I think that depending on your characteristics of your patient, for example, obesity, okay, even the guidelines recommended established cardiovascular disease first GLP-1 and then
yes.
I think that now we start to have evidence that also with SGLT-2 inhibitors you decrease cardiovascular disease. If you have heart failure, of course, there is no question. I mean, and if you have kidney disease also, there is no question. Okay. The area of established cardiovascular disease is a little bit more open. The ideal, both.
Both. Okay. So how is current situation in Italy? How you decide when metformin is not enough? You can use SGLT-2 or not? Completely freely, so it's fully
it's
reimbursed.
Not free. Only diabetologists can prescribe.
Okay.
You have a therapeutic plan.
Okay.
Otherwise, the GP cannot give it. You need to renew every 6 months for SGLT-2. Until a few months ago, reimbursement was only for one, either SGLT-2 inhibitor, GLP-1, or DPP-4. Now we are starting to improve. And you can have reimbursement for an association of SGLT2 DPP4 and only for DAPA, I don't know why it's only for that, and exenatide slow release, you can have reimbursement for both. But this is very recent. So I hope that this will continue to improve. But it's still only in the hands of the diabetologist.
What is your opinion to put it in the hands of GPs? What's your opinion on that?
Yeah.
Do you have any concerns regarding that?
No, absolutely not. I think it's a very safe class of drugs. They need to be educated because you see the problem in Italy, because they cannot prescribe, they are not well educated. But even with DPP-4s, because they cannot prescribe, that would be ideal everywhere in the world. GPs can prescribe, except for Italy. I'm not sure about Spain. I think GP is easy. I mean, the safety profile is very easy.
Okay. Let's just briefly touch type 1. How is your clinical experience with type 1? Do you use it in your center? Also as add-on as adjunctive therapy?
I do predominantly type 2 because I work in internal medicine and we have some diabetes clinic. But in the diabetes center in Padova, which is run by Angela Vogaro, they use it in type 1, yeah. But I think that is a very tricky, difficult area because it takes education. But to me, it was very interesting when the first trials with SGLT2 inhibitors in type 1 were published with SOTA and DAPA. I couldn't understand why with one there was an increase in DKA, with the other not. And DAPA was not. So I read carefully the methods, and it was all about monitoring, measuring ketones. So I think that if you educate the patients not to decrease too much fast-acting insulin and to monitor ketones, you can minimize the risk. Of course, there is the risk. But I think that there are more and more patients with type 1 diabetes who have problems with obesity or overweight. So if you can decrease the dose of insulin, that's important. Glucose variability seems to improve. We should never translate type 1, type 2, but if it's true in type 2 that you have primary prevention of heart and kidney disease, think about a patient who is young and has all his life in front, that should be. But we need studies.
Any questions from the auditorium?
Just a quick question.
Yeah.
Do you have equal protection by these drugs across all diabetic patients' population regarding of the diabetes glucose control? So,
Yeah. No, because it heavily depends on the renal function. So if you have a very good renal function, if you have a GFR 120, your glycosuric effect will be maximized. If you have a GFR of 40, you have a very small improvement in hemoglobin A1c. Because if you filter less glucose, you inhibit some reabsorption, but the effect on blood glucose will be less. So it depends on renal function. Of course, as with any drug, there are patients who are non-responders. It's not described in any trial, and I would really like to know. But I'm sure that the patients take the drug because they have glycosuria. So I don't know why that is, but that's true with any drug, and some patients do not respond properly in terms of glycemic control. I don't know if this is due to the fact that maybe if you inhibit SGLT-2, you have an overexpression of SGLT-1, so you manage to reabsorb, but for sure. The same is true for the antiproteinuric effect. You have some patients where you have a dramatic decrease in proteinuria, like 70%, and some where you have very little. So from the trials, what they provide is the mean value. The mean is 40. But you have patients who have a lot of reduction and patients who have very little.
when you divorce glucose control from other benefits, what crossed my mind, there is something that we don't know. It is some metabolic effects all over that maybe we are missing.
There is a lot that we don't know.
Well,
That's why I like these drugs so much, because we know that patients die less. We know that patients have less heart failure. Less patients end up in dialysis. Now we need to understand why, and we don't. We have some ideas. Hemodynamic effect for sure, diuretic effect on. Can you explain to me why, if you have a GFR of 40, you don't have an improvement in glycemia, but still you have a decrease in blood pressure and body weight? So there is a lot that we still need to understand. But the thing is that they work. So I think that we need to understand why.
I'm a fan of good science.
Yeah.
And you have to admit, in the 21st century, there is a less and less good science, a basic science. This is my own opinion, and I take all responsibility for this. I had a friend from Erlangen, we met more than 10 years ago. And when I heard his lecture, listened to in Budapest, I couldn't sleep whole night. So this is a sign that science is good when I don't sleep. He did measure, he showed that sodium in a plasma has nothing to do with sodium overload in the body. And he introduced the concept of nanosmolar sodium storage. Siemens to make MRI for sodium.
Yeah.
And what they did, they measured sodium stored in the skin and muscle,
Yeah.
Regardless of, and which is different than sodium in the plasma. And then he concluded that sodium in the plasma, this is what we measure all the time, has nothing to do with whole sodium content. In regard with SGLT-2, they show that when you put patient on these drugs, this sodium storage gets cleared in the skin and in the muscle. So he's now in Singapore doing clinical trials, trying to show that this beneficial effect, at least, well, for the most part, is coming from this effect.
Yeah. We always talk with these drugs about the natriuretic effect, right?
That's right.
Yeah. But in fact, the sodium concentration in the blood does not change and should not change. Otherwise, you would end up with problems like not sleeping, but sleeping all the day because of low sodium, right? I think that the finding that the content of sodium in the skin is decreased is consistent with the idea that the extracellular amount of sodium in the body, which is increased in type 2 diabetes, there are plenty of evidence, is probably improved by the treatment with these drugs. But I agree with you that there is a lot of information that we are missing.
We have two more questions here on the screen. Do you use SGLT-2 inhibitors in CKD patients as an off-label drug? Let's discuss both. Let's say.
I mean, in patients with diabetes, I use it before.
So even if
I'm
OGFR is lower,
comfortable,
you're comfortable. Okay.
I never went below 30.
30, okay.
Because I stick with evidence, even if the label did not change yet. As I said before, first of all, I have also done some clinical trials in patients with GFR down to 30, and I didn't have any problem. And from credence, we know that side effects are... So I don't think that I feel comfortable doing that.
There is another question here. Type 2 diabetic patients with myocardial infarction, would you choose GLP-1 or SGLT-2? Can we protect this patient better with SGLT-2? Also regarding potential development of heart failure and CKD. So after myocardial...
Well, we did not have any evidence that in patients with a previous MI, there was really a reduction in recurrent MI or cardiovascular death with SGLT-2 inhibitors. But that paper that I mentioned before, I don't remember the first author, on circulation from Declare team, clearly, I mean, having that huge number of patients, of course they can do this. Patients with MI, previous MI, on dapagliflozin had a significant reduction in the risk to have a recurrent MI and a significant reduction in cardiovascular death. As a plus, as in all trials, they have a reduction in the risk of hospitalization for heart failure. And in a recent analysis of Declare-TIMI, we have also learned that patients receiving SGLT-2 inhibitors have a decreased risk to develop atrial fibrillation or flutter if they had previous cardiovascular disease or also if they didn't. So I think that at this point, I would, let's say, not only decrease the cardiovascular risk picking an SGLT-2 inhibitor, but also decrease the risk of heart failure and advanced kidney disease.
There is also a question on a different patient population without diabetes and kidney protection. You're reviewing these articles. What's coming up?
There are two trials in patients with CKD without diabetes. The first one that will be completed is the DAPA-CKD, which will be, is event-driven, but in theory it should be completed by October. And in this trial, patients with proteinuria of 200 and above, and with GFR between 25 and 75 have been enrolled. And these patients can have type 2 diabetes or can have other renal diseases without diabetes. So that will provide information. A similar study started more recently with empagliflozin and is EMPA kidney, enrolling type 2 diabetic patients, type 1 and non-diabetic. So the idea again is that the renal protective effects have very little to do with glucose. But we'll see.
Okay, there is another question here on type 1 patients population. How often do you suggest them to measure blood ketones per day?
This you should ask him, because I do type 2 basically.
Actually, we have also Professor Battilino here. He was one of the main authors of the consensus also. And it's quite tricky how often there are very exact recommendations, but per day it's very difficult. It's more about clinical situations, symptoms, and so it's really difficult today. Maybe can you comment?
It's not clear. So there is no recommendation per day, and it shouldn't be, I believe. It's not an easy thing to do. It's recommendation on how you choose your person with diabetes. And of course, if the person is sick, actually, the recommendation is to discontinue as the first thing. And more important probably is that physicians that actually get these people with diabetes to the emergency measure ketones. So it's very focused on this part, and we try to work now with the Emergency Medicine Association in Europe to teach them actually that people with not very high glucose and type 1 on SGLT-2 can get serious ketosis and ketoacidosis. But there is no recommendation how many times per day. So whenever they are sick or don't feel well or forget insulin, because all this happens only if insulin is not injected.
No, I was talking the recommendation for the patient, not on how many times to measure ketones, but in general, I think that it has been a very important effort to put together the document, because if you carefully select the patient, and then, again, this is not a drug for the sick days, also for type 2, by the way, I think that you can minimize the risk.
Right, and probably there are obvious benefits to it, so it will become more often. By the way, there are sensors in development that measure continuously ketones in addition to glucose, which may facilitate considerably the use of these drugs.
Yeah. Thank you.
What about this effect on LDL? We all know that the LDL goes a little bit up, and the majority of patients are using statins as well. Do we need to adjust the dose? How clinical relevant problem is this LDL
I just saw a paper, I didn't have the time to, by a group of investigators from Daniel van Raalte from Amsterdam. They did a very nice study, very complicated, on lipid metabolism and lipid fluxes in a small number of patients, of course. And basically, they measure the LDL, they measure different subclasses, and on top of rosuvastatin, and they didn't really find any major effect. In the clinic so far, I've never had the need to increase the dose of a statin or to add ezetimibe or something when I gave SGLT-2 inhibitors. But I don't know what's your practice.
Major problem
Also, usually, you have a decrease in triglycerides and a small increase in HDL. So overall, LDL should not really change. In this very, very carefully done study, there was no change in LDL at the end.
We have some endocrinologists also here attending the meeting, and there is a question regarding acromegaly. In acromegaly, natriuresis is also decreased. Are there any data on SGLT-2 on kidneys of acromegaly patients? Are you aware of any?
No, I'm not aware of any, although this would be, I don't know if it's correct to say a model, an interesting model because they have glomerular hyperfiltration. Because growth hormone increases renal plasma flow and GFR.
I'm a bit reluctant.
I'm not aware of any study where they described patients with one kidney, but I'm aware of studies done in patients with kidney transplant. There are trials going on in patients with kidney transplant where, in fact, there were no problems at all. Now, if you think that, if you believe that the hemodynamic effect is important, then the single kidney should be the ideal model because you have half the number of nephrons and they hyperfilter. Yes. So I think that it should not be a problem, but I've not seen any report of description of cases. Usually, if you have only one kidney, your GFR is not that much decreased if you don't have something else on that kidney. Do you agree? I mean, serum creatinine should not be that increased.
Yes, sometimes it's a bit higher, but generally it's close to normal.
Exactly.
But I'm a bit reluctant in starting SGLT-2 with solitary kidney. Do you think it's safe?
I think it's safe in that. What are your thoughts? It's not that you are thinking like RAS inhibition, stuff like that. I mean, what can happen is that you have a slight worsening of creatinine, so GFR goes down a little bit. I would expect for GFR then to go back to baseline in a few months. But what should be good for that kidney, if you believe that hyperfiltration is bad, is that you decrease intraglomerular pressure.
Yes, that's why logically it would be that this kind of drugs would be appropriate for such patients.
Exactly. I mean, like for the kidney transplant patients.
Yes.
I would be skeptical because for me, infection in a patient with immunosuppression is always a problem. But I have been invited to a sort of working group, National Kidney Foundation in Chicago, on SGLT-2 inhibitors in kidney disease. And they were pushing very hard towards studies done in kidney transplant patients with diabetes. They presented already some reassuring data. In theory, again, if you improve hyperfiltration, you should decrease the risk to develop in that single kidney diabetic kidney disease.
Yes.
But I've not seen any report on that.
Yes. And I would have another question or a comment. I had 2 patients on SGLT-2 inhibitors who developed significant increase in hematocrit and hemoglobin. If you discontinue the drug, they normalized. Mm-hmm. And when we restarted again, it went up again.
Of course.
But these were significantly higher above normal. So I'm a bit reluctant. How about such patients? Should we discontinue the drug if this happens?
So you worry about hemoconcentration,
yes.
excessive?
Yes.
I mean, now, if you look at all the trials, there is an increase in hematocrit. And again, what the trial give you is the mean value. Okay?
Yes.
So what you are picking here is the super responders in terms of probably diuretic effect and hemoconcentration, or in terms of erythropoietin production. Now, if you worry about viscosity,
yes.
you can think of stroke, I guess.
Yes.
And we know that the initial warnings or worries about stroke coming from the first month of the canvas patient, they have not been confirmed. Of course, it depends on the patients, on the clinical characteristics, but I'm not surprised that as for different aspects, you can have patients who are hyper-responders and patients who are hypo-responders.
Yes, I'm aware of that, but should we discontinue the drug in such patients?
I wouldn't. I don't know which kind of hematocrit do you...
It's like 0.55
okay.
in a male and a hemoglobin of 190. I even sent him
190?
Yes, and I sent him to hematologist. He performed all the tests and they were all negative. So when we discontinue the drug...
And when you discontinue, it goes back to which hemoglobin?
175 or so.
Well, but 175 is already high.
It's already
So
high,
this
but it's still sort of on the high normal.
Is a polyglobulic patient. I mean, 175 is not normal. So
Yes,
it's not an hyper-responder. It's responding. If you have 140, you know.
No. He was already on the higher level, but when you gave him the drug, he just... So we discontinued. I didn't dare to...
Probably I would, with those
Continue.
levels, I would discontinue.
Yes.
Yeah. But I would worry about something else going on.
Yes, he had all kinds of investigations with hematologists. They said that...
Well, put an eye, because it may develop something.
Yes.
There was another question, and you just mentioned this stroke issue after discontinued CGLT-2, like with Imparec, it was an issue.
Yeah.
Is it of clinical relevance now with this long-term use?
Yeah, there has a lot, of course, going on with this issue. But we have, after Imparec, we have now more and more data with really huge numbers of patients, and it doesn't look like being really a problem.
And there was just one more. Do you recommend CGLT-2 in type 2 with multiple risk factors for CVD? I don't...
I mean, I have a problem
I don't know
here.
who wrote this.
I mean, I have a conflict of interest. I think that with the evidence we have, we should give, as I wrote, SGLT-2 inhibitors to most, if not all, patients with type 2. Having said so, and going to what is proven by science, which I understand trials to you are not science, right? I kind of agree. I think... No. I think that there has been a huge change because science these days is done by PhDs. In the past was done by us. Now what we do is clinical trials, or if not trials, clinical research. Basic science is done by PhDs only. And that is a pity because as doctors, we always have in mind the patient. So even when we do basic science, we have, right? Exactly. So that's a problem. But anyway, going to evidence, declare which % of patients didn't have any cardiovascular disease at baseline, the majority. And still, you had benefits for cardiovascular disease, heart failure, and kidney disease. So my answer is yes.
Maybe just to summarize this talk, what's interesting, what's coming this year? You are reviewing so many articles for these prestigious journals. What are you specifically looking forward regarding this therapy in the near future?
This year?
What kind of data, or
well, I look
years?
forward to hearing something about, I would like to know more about mechanisms, but when it comes to trials and to clinical issues, what I would like to know is if this drug, I have a bias, I'm interested in the kidney. I'd like to know if these drugs work also in patients with chronic kidney disease without diabetes, and I hope that the DAPA-CKD will answer that question. And I would like to know whether SGLT-2 inhibitors have a beneficial effect in terms of heart failure and cardiovascular death in patients with preserved ejection, with the heart failure with preserved ejection fraction, which are the majority of patients with heart failure and that type 2 diabetes. So that is what is coming soon, and I hope to hear soon about the results.
Thank you so much, Paola. Thank you again for coming to Ljubljana.